Hey there, I'm Dr. Aaron Kovaleski, and today we're going to be talking about chronic musculoskeletal inflammation, which is a whole mouthful, but if you're watching this video, it's probably because you have some form of chronic musculoskeletal inflammation, but for you, it may be knee pain or elbow pain or hip pain or shoulder pain. Regardless of where your symptoms are, the process by which you have these issues, it's all the same thing. So we're going to be able to discuss this in some broader terms, but we're also going to discuss treatment options, which you may already know some about, why you have the issue in the first place, and what can be done about it, and how we can help you here at ECCO Medical. So moving on into the discussion, let's discuss the symptoms that you can have due to this inflammation. So the symptoms will depend obviously on the joint where you have the symptoms. However, it's pretty much all going to manifest the same way. Specifically, with increased usage, there is more pain. Additionally, the way that you get this inflammation in the first place is from increased usage for a variety of reasons of whichever joint is bothering you. As an example, if you have arthritis in your knees, it's from using your knees, which we don't really have a choice, but we have to use it. And over time, there's wear and tear that can occur in the knee, which would cause you pain. For those people that are avid golfers or avid tennis players or weightlifters, they can get elbow issues such as tennis elbow or golfer's elbow, which is fancier words are medial epicondylitis or lateral epicondylitis. That is just an overuse injury where the muscles, where those tendons attach to the bone. And if you're using that repetitive motion over and over again, that stress on the bone and in that ligament or in that tendon, that's going to cause this inflammatory process. Picking up where we left off discussing chronic musculoskeletal inflammation, let's talk about exactly what inflammation is and why you get it. So inflammation is actually a part of your immune system. If you get a paper cut, your inflammatory response is stimulated and a series of things happen in a very specific order to allow for healing. Okay. This also can occur in our joints. So I'm going to use the knee as an example. Over time, we have cartilage that lines the femoral head or the big bone on top, and then the tibia, which is the bone below that. Where those two bones join, they have this cushion in between them, but that can wear down over time due to age. People that have a more vigorous, active lifestyle, runners, athletes, weightlifters, that cartilage will wear down sometimes sooner than those that don't do those vigorous activities. After a while, that padding wears away and it becomes bone on bone, which you may have heard if you're watching this video for your knee pain. When the bone has friction, it injures the other bone every single time with every single step. So you're getting a new injury with every single step. Well, anytime that you injure any part of a joint, that's going to stimulate the inflammatory cascade to heal that injury. But if you're injuring it over and over and over again, that means that inflammatory response is getting stimulated with every single step. Okay. So that's why during the day it gets worse, because you're re-injuring that joint over and over and over again with each usage of it. And that's why you probably feel the best in the morning with those issues before you start walking around or just using your arms or whatever joint is bothering you. What happens with that inflammatory response is your body makes these makeshift vascular beds or little capillaries. They're not like normal healthy capillaries. In fact, these have more holes in them, which allow cells that are part of the inflammatory process to get to the injured part and get out of the blood vessels and start doing its work and healing that part of your body. With chronic inflammation, meaning inflammation that is happening constantly over and over again, that scaffold of blood vessels never leaves. It stays, and that allows more what are called inflammatory cytokines, or essentially pain causers. They stimulate the nerves in that area, and that sends a pain signal to your brain, so you have pain due to the inflammatory response because of those blood vessels that are there. With a normal healing response, those blood vessels eventually are resorbed and they disappear. but with chronic inflammation, they stay. This is important to understand how our treatment works here in a moment when we get to that part of the discussion. On the flip side, we discuss knees. If it's in your elbow, it's due to that repetitive motion. The ligaments the tendons are pulling on the bone over and over and over again with whatever action you're doing, whether or not it's golfing or playing tennis, lifting weights, etc. The same thing can happen in your hip with whatever hip motion you're doing. So like horseback riders, their hips are flailed out. So that's going to be the same process occurs there with the hips. Shoulders are a little bit different. That can be known as frozen shoulder because they have limited mobility in that shoulder. That can be due to inflammation of the capsule that covers the shoulder joint. When that becomes inflamed, it can actually become stiffer, making it more difficult to move that shoulder, and it hurts more with activity and therefore decrease the range of motion because of that. So the point is, it doesn't matter where in your body that you get this, or that you have these limitations with your joints, it's all caused by the exact same process, which for someone like me in my field, that makes it a little bit easier to treat people no matter where they're getting their inflammation. The next thing that we're gonna talk about is workup and diagnosis of chronic musculoskeletal inflammation. Moving on to discussing diagnosis and workup of chronic musculoskeletal inflammation. How do we know what it is? How do we find out that you have it? How do we give you that so that way we can come up with a treatment plan? So first of all, workup, a lot of it's going to be clinical. So what your symptoms are. So the questions that you could be asked by a primary care doc or a physical therapist or a surgeon are going to be, what are you doing when the pain is noticed? And maybe it's just walking and you say, well, the longer I walk, my knees hurt. And they say, okay, well, you have knee arthritis or inflammation in your knee. Or you say, my shoulder, I'm not able to move it that great. And the more I try to move it, the more painful it is. Okay, well, you have, frozen shoulder. Additionally, there's going to be some physical components as well. If they can reproduce the pain in clinic doing certain motions or whatever else, then they know that that's exactly what you have. If it's your elbow, they can say, oh, well, you play tennis all the time and your elbow hurts on the outside. Oh yeah, well, you have tennis elbow. Or if you golf all the time and your elbow hurts on the inside, it's that. So diagnosis is partially clinical. In some cases, if it looks a little bit more confusing, because maybe you sustained an injury or were in a car wreck and then that pain happened after that, they might get x-rays, they might get MRIs. We may order those as well if we're the ones doing the workup, just because we want to look for other things that could be causing your issues. Because what we don't want to miss is something that could be a bigger issue or treated in a different way, because we don't want to do an unnecessary treatment on you. We want to make certain that we're targeting and treating the correct thing causing your pain. The next thing we're going to discuss are the multiple treatment options for chronic musculoskeletal inflammation. Let's discuss the treatment options that you have for joint pain due to chronic musculoskeletal inflammation. Pretty much for every joint, no matter where it is in your body, you're always going to start off with what are called conservative measures. That's going to be things like, well, if you're playing tennis all the time, hey, let's try not playing tennis for a while, right? And maybe that will help out with your elbow. Or something like wearing a brace. You can wear a brace on your knees, on your elbows. You can wear a shoulder sling, things like that. Some sort of bracing or support mechanism for the joint that's giving you issues. Additionally, there's going to be medications that you can take. You can start off with over-the-counter things like ibuprofen, which is a non-steroidal anti-inflammatory drug. There's that word inflammation again, an anti-inflammatory drug. Aleve is another one. You might get a prescription strength one like Mobic or meloxicam as its generic name is. And then other things, depending on where your injury is located or where the inflammation is, surgery could be a treatment option. For your knees, it might be a total knee arthroplasty. If you don't have a lot of cartilage, then they would go in and just put in a joint replacement in the hopes that would get rid of your pain. The same thing could potentially happen in the shoulder as well. But those are not going to be as commonly done as, say, a knee, just because success rates for pain relief with shoulder replacements just aren't quite as high as they are for knees or hips if you have hip pain. So now let's move on to the way my treatments work, the embolizations. So now let's discuss how embolization works to treat chronic musculoskeletal inflammation or joint pain. All right, so my field just exists with pretty much doing the same thing over and over, no matter where in your body. So if you're gonna have any kind of embolization done, the first thing that's gonna happen is a needle stick to numb up the skin, so that way I can then advance a needle using ultrasound guidance into the artery that I'm gonna treat. So if it's your elbow that's bothering you, I'm gonna do a needle stick into your forearm, into an artery that I know is feeding the inflamed part of your elbow. If it's your knee, I'm actually gonna stick your ankle to go up to your knee, so that way I can find the blood vessels that are causing the inflamed part in your knee. Same with your hip, I'm gonna stick actually your ankle, I'm just gonna use a longer tube to get up to your hip and find the vessels that are feeding the inflamed part. Everything I do is the same no matter what. It's a needle stick into the artery, then I advance a wire through that needle, and then that needle comes off over the wire, and then I thread tubes over that long wire into the blood vessels using ultrasound and x-ray guidance, and then I can inject what's called contrast or dye. It's essentially iodine salt water that reflects x-rays so I can see it up on my screen. And then through that tube, I can then get into the target blood vessel that I want to treat. And then when I'm in there, I inject what's called an embolic agent. What I'm doing is I'm trimming down the blood supply to that inflamed portion. And if you remember from an earlier discussion, we can see those blood vessels that are not really supposed to be there. Those makeshift scaffolding blood vessels that are caused by the inflammatory process, we can see those on x-ray when we inject the dye that we inject. And then I know I need to inject my embolic agent into that to stop the inflammatory response, which then stops the pain and gets you feeling better and improved range of motion and getting back to a better quality of life. So like I said, it just depends on what joint I'm treating. If I'm treating your shoulder, I'm going in through your wrist and then going up to the shoulder on the same side. If it's your right shoulder, I go on the right side. If it's your left shoulder, I go on the left side. If it's your elbow, I get a little bit closer, I go in the forearm. If it's your hip, like I said earlier, I go through the ankle. So I pick my access point depending on the joint that I'm treating. And then it doesn't matter what I'm doing or which joint I'm treating, I'm still gonna go in and inject no matter what. Now, a very commonly asked question is, what is it that you're injecting that's cutting off this blood supply? So we don't implant anything permanent for this procedure. There is an antibiotic that some guys that are really smart in Japan, they discovered that when this antibiotic, the powder form, is mixed with the contrast we use, or that dye, that iodine salt water that I mentioned, that iodine bonds to the antibiotic, which takes away the antibiotic properties of it, and then it forms a crystal when it's mixed together. And these crystals are very, very tiny, about 40 microns in size, about the size of a capillary. So we inject these crystals under x-ray guidance into these tiny little blood vessels, and they go in there and they lodge in those makeshift inflammatory scaffold blood vessels, and they cause those blood vessels to resorb because they no longer have blood flowing in them. They go away, they disappear. So that inflammatory response gets diminished or completely eliminated based on those crystals. Those crystals will also dissolve. They go away within 6 weeks. So there's nothing permanent left behind. And the volumes that we're injecting, it's not like I'm putting in, gallons of this stuff. It's usually a couple milliliters, which is not a lot. So it's, maybe 2, 3, 4 milliliters of this stuff, and then that's it. The procedures overall, because of the access point where I can be close to the joint that I'm treating, and the fact that I don't have to inject that much material once I've found the inflamed part, procedures usually don't take that long. Usually about 20 to 30 minutes, sometimes longer if there's some challenging anatomy or some other issues, but for the most part, they take about a half hour. In our next segment, we're just gonna talk about the patient experience for these procedures when you do come to ECCO to get this done. So continuing on with our discussion about musculoskeletal embolization for chronic inflammation, let's just talk about what a patient is going to go through on procedure day. Okay, you're usually going to show up an hour before the procedure. For other things like plantar fasciitis embolization, not as much time is needed beforehand, so usually a half hour. The amount of time before the procedure determines whether or not you're getting moderate sedation. We do offer that for every single patient. There are some people, if they know the procedure is only going to be 20 to 30 minutes, they would rather just walk in, get it done, and walk out. That does shorten your amount of time here at ECCO in the office, shortens your recovery time as well, and you're not going to be groggy the rest of the day. But let's say you show up an hour before, you come in, you get into your gown, we start an IV, you and I talk a little bit beforehand, just answer any questions, go over everything else. Then we bring you back to the x-ray room and we put you on the table. The x-ray machine is over you. It's a C where you've got a part of the C arm down here and a part up here. So you're not enclosed like in an MRI or a CAT scan. The C arm can move in and out. And so the x-rays are going to be emitted from the bottom and detected at the top. So I move that around as I need to be able to see the angles that I need to see and see the blood vessels that I need to see and get in there. If you're sedated, you're not going to remember the procedure. You're not going to really feel much of anything during the procedure at all. You do recover for an hour afterwards. No matter what we're embolizing that day, no matter which joint, you will have some sort of pressure dressing on it for about 30 minutes to an hour after the procedure at the puncture site. That's just to avoid any kind of bleeding or anything like that from the procedure or from the needle stick. Other things to anticipate for after the procedure: we're always going to put patients, unless there's some reason that you can't be on it, some form of medication. It's typically going to be a steroid dose pack that goes on for 6 days just to help out with any kind of inflammation that's still left over after the procedure and get you some relief a little bit quicker. There are some people that can't tolerate steroids, so we'll put them on a dose of NSAID, a non-steroidal anti-inflammatory drug. We usually use meloxicam. And then there's some people that just don't want any of that, and that's okay too. In extreme cases, people that do have severe pain, we will prescribe some pain medications like oxycodone after the procedure. That's not all the time, that's not every patient, but some patients are in significantly more pain than others, and we do want to get them some form of relief quicker if we can. In our next segment, we're just going to go over recovery and results. So finishing up our discussion about chronic musculoskeletal inflammation, let's talk about recovery and results of this procedure. Recovery is pretty minimal no matter which joint you're getting treated. Typically, you may have 3 to 4 days of a little bit of discomfort in the joint. Most patients say that the joint feels a little full, and they have some limited motion in the joint for a few days after the procedure. That doesn't happen to everyone, but I would say it probably happens about a quarter of the time. Maybe 1 out of 3 patients have that experience. Otherwise, people just go back to feeling however they were before, except unless they're on steroids. So I try to tell every patient this as far as expectations go. It takes at least 2 weeks for patients to see results from the procedure. So if you're on steroids, a lot of times your symptoms get better right away and you feel like the procedure was a miracle because you started your steroids. That's the steroids that's dampening the inflammatory response and allowing you to feel better and get back out and do stuff. So after 6 days, your symptoms come back a little bit because you stop taking the steroids. And then after another week, you start getting better after that. So there is a little bit of a patience factor here where you have to allow for at least 2 weeks before you start seeing results. When you do see results, depending on the amount of pain you're starting off with, if you're a 6 out of 10 pain or a 5 out of 10 pain person, you might not have as dramatic results as someone that's in 10 out of 10 pain all the time, right? Because if you have a person that's in 10 out of 10 pain, they would be so happy with 8 out of 10 pain, right? Because that's just so much better than what they're already dealing with. So the results can vary for each patient because it is also a very subjective thing, right? So people that have less pain, they're not going to have as dramatic results. One of the things we do to track these success rates is that with every joint, you will have a survey that's filled out. That's a scoring system that lets us understand your functionality, your pain levels, etc. And then at every follow-up afterwards, you're going to take that survey again because we track those numbers. So for example, with knees, we have what's called the WOMAC score. If you're at a 76, when you fill out the survey the first time, we're going to have you take it again at your 1-month follow-up. And hopefully we see that down into the 30s and then the next time maybe even down into the 10s. So we track your results based on that. It is completely subjective. Of the studies that have been done with these embolization procedures, about 80% of people report significant pain relief, which is a huge number. Additionally, what's really great about these procedures, the results are lasting for up to 2 years with some of these procedures. So the expectation is a year to 2 years of relief, meaning you're off medications, you don't need injections, you don't need surgery, you have that relief, your quality of life is improved and your range of motion is improved. So the amount of time that these procedures can work can be pretty significant. Now, we've had some extreme cases where people, with plantar fasciitis, they've had surgeries and Achilles relocations and new tendons put in. With a patient like that, when they've had so many things done for a chronic inflammation issue, the results of our procedure are probably not going to be as dramatic just because there's so much scar tissue there. There's so many nerve issues because of the surgeries as well. Someone that comes in with plantar fasciitis that they just got out in the wild just from overuse, this procedure has a very real chance of providing meaningful and lasting relief. So thanks for watching this video. I know it's a lot of information and I know it can be a concept that's pretty difficult to grasp. Strong recommendation, if you do still have questions, watch the video again. Sometimes you'll miss some things the first time through and more questions will be answered. But additionally, you're gonna be having a consultation after this video with one of our providers. They'll be able to answer a lot of questions. And again, if you do opt to get this procedure done, you are still gonna be talking to me on procedure day. So you've got numerous opportunities to have any and all questions answered. And please don't be shy, ask away. We're here to help. We want you to get the best result possible, and we want you to be as educated as possible before you decide to get treated with us here at ECCO.